Um, yes, I'm Chris Montrowl from the University of Florida Health Shands Home Care. Go Gators. All right. I was hoping to run into Steve Spurrier last night, but I couldn't find him. Yeah. Um, One thing you may not know is those of us presenting today as part of the pilot agencies, we haven't seen the other presentations from the other presenters. So it was very interesting for me to hear, as I'm sure it was for you, and I couldn't help but notice all the similarities. So I'm sure you guys have these same issues and concerns and challenges that we did as we went through this. Even Annette and Kathy's introduction with those points that they covered, I could have used those almost exactly and incorporated them into my presentation. And so it wasn't just unique to one agency. It was pretty cool to see that. So my part of the presentation is to focus on improving hospital procedures and measuring results related to face-to-face documentation. Now, just a little bit about our agency. We are a department of Shands Hospital at the University of Florida. Approximately a little over 60% of our patients are Medicare. So y'all know what that means, over 60% requiring face-to-face. Our referrals, probably about 64 to 66% come from our acute care hospitals, and then the remainder from the community and clinics. And we have an average patient census between 500 and 600 patients. And I should say one of the challenges, not only are we a teaching hospital, but something, and I don't know if this is unique in the academic setting or not, but an additional challenge for us is the physicians at our hospitals don't work for Shands Hospital. They work for the University of Florida College of Medicine. So whenever we have issues, we can't just go to the CEO of the hospital and say, make Dr. Smith sign this form or fill out this form correctly. So that's a challenge in itself. It's almost as if we are an independent agency sometimes. So the challenges we identified from the beginning at the start of this project, and by the way, I was perfectly willing to participate on this team when I was asked, but I didn't know at the time that I was going to have to be here presenting. That may have changed my answer. But anyway, so some of the challenges, unclear requirements that was mentioned this morning. We thought we were doing it right for the first 2 years, and then we found out not necessarily. Physician and non-home care staff lacked the knowledge, the home care regulatory knowledge. We've also heard that. Who really gets that information to those physicians, to those clinics? Really, it falls on us to educate. Referral source frustration as well as physician frustration. A lot of that had to do with the rework. We're going to talk about that in just a minute. Again, thinking a particular form is acceptable, and then we have to go back and say, no, it's not quite right. It doesn't meet the intent. And then we find out, oh, we weren't exactly clear. We go back again and again. So frustration on the referral source and physician's part. And then, of course, ADRs, denials, and then all the rework that's involved when it's not done correctly up front. So our team members On the left side were the people directly involved from the home care agency. And we had a good representation, people from billing, finance, QA, IT, our business development reps. So we had a good representation of everybody on the team. And then on the right side, the top part, those were people that were directly involved at one point or another in our team meetings. Either they came to us or we went to them. But then we also had a group that didn't necessarily participate in the meetings, but that we reached out to throughout the process. Here's just a few pictures of what went on during those first 3 weeks. 3 days of meetings for 3 weeks. And you've seen, the process maps up on the walls. Lots of fun there. When we got started with that, we were thinking, man, what did we get into? And that's our baseline map, similar to what you see over there. All the red were barriers, so sometimes we felt like we had more barriers than actual steps in the process. And here's a partial list of those barriers that we tried to summarize. So I'm just going to highlight a few of them. Physicians being contacted numerous times to sign forms, to fill out forms correctly. Face-to-face in EPIC, which EPIC is the hospital's electronic medical record system. Not always completed. There's some templates that were created, but you know how that goes. You can't fill out the information for them, and template is just kind of a guide. Doesn't guarantee that it's going to be filled out correctly. Getting incomplete face-to-face documentation with referral. That was a big one for us. And that was one of the things, and we're going to talk about that, but that was one of the things we identified we really need to focus on, getting that complete and correct up front. The cosignature issue for us was big just because of the amount of work that it took. When we mapped it out on the wall, we saw the circles and redoing and checking this and checking that, and then either Kathy or Annette mentioned earlier, and then we get to the end, ready to bill, and it still wasn't right. How does that happen? So we really wanted to focus on getting it right up front. And then, of course, just incomplete orders and that kind of thing. And I will point out the last bullet item, an additional 26 out-of-scope barriers that, again, we had to put to the side. Okay, so we eventually ended up with a future state map, which is how we wanted the process to look. So that's obviously much more easy on the eyes than that other baseline map. So out of all that, we had a list of initiatives, probably a dozen at least top ones. Just wanted to highlight 5 here, and then we'll talk about 3 in detail. Again, removing the cosignature. We felt if we could get around that, that would solve a lot of our issues, because again, the tracking and retracking and sending and faxing, and it just was crazy. Almost a full-time person dedicated to between orders tracking and face-to-face tracking. That's all they did. So an easier process that didn't require an actual cosignature on the face-to-face documentation was one of our initiatives. Also, putting in a hard stop at intake, as I mentioned, getting it right up front. And when it's not, addressing it right then and there. Training our referral staff to not just be satisfied to get a form, but actually look at it. All our intake people are nurses. So we've trained them. What are the elements that are required? And if it's not in the format of an actual form, go to the electronic medical record and look for that physician documentation, which is really the preferred method anyway. Also, tracking of the issues on the front end. Again, we really wanted to make a difference getting it right up front, not waiting till that billing audit. By the time you get to the end of a 60-day episode, you're already 2 months from start of care. If the billers, might take, 2-3 weeks, maybe 4 weeks before she gets all the billing audits done, then it has to go for clinical audit. So it could be, 3 months. And then we find issues with the face-to-face documentation. Again, it goes back to the frustration. Then we're kicking it back, trying to find the physician or find the hospital case manager saying, this wasn't quite right. Do you think you can go talk to the physician and have them provide more documentation? Education. And again, a challenge for us, not probably unique to us, but hundreds and hundreds of physicians, residents, clinics. There's just no way our group, could reach everybody. So we rely on our marketing reps to do education continuously. It's not just a one-time thing. As a matter of fact, I don't know how many of you get Tom Rowan's technology report, Home Care Technology. It's an electronic thing that comes out, I think, weekly or every 2 weeks. But there was an article recently, and the name of the article was OASIS training must be comprehensive, always available, and constantly repeated. And the first thing I thought of was, so does face-to-face education. I saw that after the presentation was done, so I didn't include that. But that's true. It's ongoing. You're not going to just educate and then you're done. And then the other thing we thought we should start working on right away, because it was kind of out of our control, really. I don't know how many people know what ESON is, but it's a product of Allscripts that facilities use to put out referrals out there, and then home care agencies subscribe to ESON, and they can see those referrals and accept or not accept. I don't really know too much about that system, but I'm told that there's a face-to-face template in there that doesn't really meet the requirements that we're looking for. So we've never tried to use that, but as part of this process we thought, well, let's see if we can reach out and try to see what it will take to get that changed. So that was another initiative on our list. Okay, so the first initiative we'll kind of dig into here is the elimination of cosignature on the face-to-face documentation. Little background, we thought that's what we had to do. We understood that a cosignature was required if a different physician was signing the plan of care than the physician that was completing the face-to-face. And yes, that's one way to address that, but not necessarily the best way. Related problems, we had frustrated physicians. We've heard, well, that's not my documentation, I don't want to sign it. Lots of resources going back and forth, trying to explain to that physician why we wanted him to co-sign another document by another physician. And then, of course, we started getting denials. So some solution ideas that came up in this process. And it kind of it took some discussion and not just on more than one occasion before the light bulb kind of went off in our group. But the certifying physician does not have to actually co-sign the face-to-face, but simply sign and date the acknowledgement that the face-to-face has occurred and incorporate that into his or her record. So we thought, wow, okay, I think we might have a better way of going about this. So we went ahead and started planning to remove the co-signature spots on the various forms that were out there. Some were ours, some weren't ours, some were templates in various electronic medical records, and so on. So we met and reviewed all that. We did some edits to verbiage, but the final solution was to incorporate the face-to-face acknowledgement into the plan of care, revise the templates, and therefore eliminating the need to actually obtain the co-signature. Now, we still have to provide that face-to-face documentation to the certifying physician so that he or she can acknowledge that it exists and so that they can incorporate it into their record. But we've eliminated the whole tracking of that, because we know that when they return the plan of care signed, that they've also received the face-to-face documentation, and they're agreeing that they have received it and have incorporated it into their record. So that's working out pretty well for us at this point. Now, Initiative 2 goes back to the face-to-face not being complete at time of referral. We really felt this was an area we wanted to focus on right away. Again, the back-end work was just crazy, and we had to come up with a way to streamline that. And to be honest, the idea of creating the hard stop at the time of referral came from our hospital case managers. Because these were the people that we were going back to again and again saying, you know what we told you last month that we needed? Well, we've got clarification. It needs to be like this. So these here, can you bring these back to the physician and redo them? They said, let us know up front. Don't wait. Don't wait for the billing audit. Don't wait for a clinical audit along the way. We want to know right away. Because those hospital case managers in a large facility, you know, they want to do their task and move on to the next patient. Right? I see heads nodding. They don't want to keep coming back to the same patient. I thought I had this discharged arranged. You guys accepted the referral. I thought I was finished with it. Now you're coming back, you know, a week later, 2 weeks later, a month later. I don't want to deal with that patient anymore. I've got these other patients I have to deal with. So that we did that immediately. We started screening that face-to-face documentation right up front. Again, we met with the manager. We had to get the buy-in, so we met with the manager of the case managers in the hospital. We discussed the problem and its impact, and that hard stop was their idea. As a matter of fact, it became part of their job duties. It was made clear by their boss that for these Medicare referrals that required face-to-face, that they needed to obtain this information completely and correctly, because they're with the physicians, you know, at the time. They round with the physicians, and they're the ones that could get this done properly. So it was a step added to their job expectation. And then, of course, ongoing education. So we educate and meet with them, and then we really rely on them to educate the physicians. And we will see some measures and results in just a minute related to this. I think we have some good data to show you. And as was mentioned before, the collaboration between home care and the hospital, that was a tremendous benefit from this project, resulting in more complete and thorough face-to-face documentation, less work on the back end, less end tracking documents, and increased completion rate at time of referral. So our third initiative was an actual tracking mechanism. We needed to do that. We didn't have an actual tracking mechanism for the front end. Our system does alert billing when there is not a face-to-face in the chart, but it doesn't tell them that if the face-to-face was any good or not. And that was what was happening. Was we might get a form back and it's signed and we're like, okay, great, we've got a face-to-face. Then the billing audit comes along and we've told them, it has to contain these elements. So they'd bring it to a clinical person and I'm like, no, this isn't going to cut it. So we needed something up front to try to track this and to measure our progress on getting these right up front. We had been using a Microsoft product called SharePoint anyway, and even though it was a little bit of duplicate entry for our intake staff, and you can use I won't get into SharePoint, you can use it for a lot of things, from project management to pretty much any kind of database management you want. But what we liked about it was we could have them fill out basic referral information, and when they said enter, it generated an email out to all the home care folks that needed to know about this referral. So this was one of the things during the meetings I thought, I could go in there and add a few fields so that we can start measuring when we get face-to-face documentation up front. And that was one of the things we did immediately during the meetings. And that's just a little clip of a screen print within SharePoint with the 3 new fields that I had added. The most important one being just a simple checkbox. Was face-to-face complete at intake? Now, our intake staff know that means not just that they have the documentation, but that it meets the criteria as we understand it to be. And then there's a comment box for any tracking in case they do have to kick it back to a physician or to a case manager. And then a date that the face-to-face is actually complete if it's not completed at time of intake. So that was something that was actually quick and easy for us to do right up front. And that allows us to measure the completeness of face-to-face at time of referral over a denominator of total referrals for a particular payer source, in this case Medicare. So other measures that we will be looking at will be how many days to complete, because we now have the data in a system so that we can pull that out now and see for those that weren't complete up front, how long did it take? Percent of rejected starter cares. We have an internal process where a clinical manager reviews all of the information on a starter care once it all comes in, and some of those were getting rejected for one reason or another, face-to-face being one example. So obviously that's something we can measure. Clean claims, at time when the biller is ready to bill. AR, of course, And that's pretty easy. We measure that anyway. We do that weekly. But what we don't currently do is tie that to face-to-face. So we'll be working on that. And then, of course, denial rates. So let's take a look at some data. What you see, this is the percentage of referrals received with complete face-to-face. So when we started measuring in February, we were below 10% complete at time of referral. And we've gotten better as time goes on. Now let me explain the colors. These are different referral source groups. I'm going to start with the second one, which is the blue bar, because that's just all of our Medicare referrals. So when we started this, we were at 9%. March, we went up to about 16, 17%. April, we were about 19%. May was, I think, 21 to 22, and June was a little bit higher, 22 to 23%. So overall, we were pleased to see improvement in the completeness of the face-to-face up front. Now, the first bar in maroon color, those are the non-University of Florida referral sources. And I wanted to put that in here to show that we didn't work with any of those referral sources, okay? And it's obvious that the groups we worked with had improvement, and the ones that we didn't, there's some up and down, but really overall, they're not any better, if not worse, than when we started. So I was happy to see in orange, this is our inpatient acute hospital referrals. And there was a nice jump in February. It's leveled out a little bit, but there's still improvement going on. And that's probably where the majority of the work has been, although a lot of that does spill over into our clinics. And that's also evident in the green bar, because you can see quite an improvement. They were actually the worst group when we started, and they've shown the most improvement over the last 5 months. I think, personally, as a side note, the reason the clinics improved faster than the hospitals because they were more involved in this project. They were more willing to let us talk to them, actually send people to our meetings, and participate. And we made trips to clinics and presented. Kathy Annette and Dr. Feliciano made trips with the team to several clinics. So I think they really, kind of the message got out. And even the physicians that weren't present, I think the word got out, along with the clinic managers getting that word out. And of course, whenever you're talking about a large facility such as a teaching hospital, it takes a while for that ship to turn. So hopefully we'll see the results continue to improve. This is just kind of a summary with the graphs to show the increase for both our clinics in the green and our hospitals in the orange. And then just to kind of summarize it more than anything else, overall, our total Medicare referrals, that's kind of where we are with getting these face-to-face complete up front. So lessons learned for us, we thought we were pretty much locked in to having to get the co-signatures, which of course, just led to all kinds of tracking nightmares, just tripling really the workload of our medical records people. Benefits of increased communication, education, collaboration with the hospital, all leading to better face-to-face encounter documentation. Improved billing timeliness. And then, just going through that whole process map exercise brought together all the stakeholders to develop strategies to improve the processes, hopefully reducing the denials from the RAC audits. Kind of got us to step outside the box to identify our future state, which is hanging on the wall. Help us create better workflows. I mean, we had a process flow for everything, but when we started seeing all those pink barriers, we realized that even though we had a process that we were proud of, there were still lots of barriers associated with those workflows. And then many new ideas. So long after this project is over, we can go back to that process map and see what other quality initiatives we want to tackle. And then supply chain messages. I don't know what happened to the text on the slide, but that's okay. One thing that we were discussing was, was the struggle of a home health agency who doesn't have any control over the referral sources or the physicians. It's difficult. These regulations come down. We can, learn them and understand them, but we can't necessarily force other people to follow them. So we're always caught kind of in the middle. We kind of feel like we have to be the ones reaching out to our referral sources, particularly the physicians, and educating them. And we have to be sensitive to our competition out there, because if they come up with shortcuts that we may not necessarily agree with, the referral sources will typically take the path of least resistance. If an agency will, just give me the name and we'll take care of everything else, that puts us at a disadvantage for the referral source. Even though we're part of the same health system, when it comes down to it, when you've got a case manager who has X number of patients they need to get discharged that day, they don't want to be spending a lot of extra time. And if we're coming up and saying, well, CMS says you have to do it this way, they don't necessarily care at that particular moment in time. So we have to be sensitive to that. The other thing is, related to regulatory changes that require IT system changes. That's a challenge. You've got to have time for the vendors to incorporate the changes. You have vendors that are nationwide, so they're dealing with different intermediaries, and they may have, several hundred customers themselves that, we might put in a request for something. We want it this way, but this other agency wants it a different way. And if they have 200 customers, they might see 200 different requests the way, because everyone wants it the way. No one wants to change their process. They want it the way they want it. And it doesn't matter what the other 199 agencies are doing. So it's hard to please everybody, for the vendors. So that's a challenge. And I've also heard from software vendors that they don't always get the memos and the regulatory changes from CMS. They try to stay on top of it, but a lot of times they rely on the customers to say, "Yep, did you see this memo that just came out? You better start working on your software changes because deadline's coming up quick." So that's kind of a IT challenge that we have to face. So are there any questions for me that I might be able to answer? Yes.
I have a question about the cosignature.
Yeah.
I'm still under the assumption that if it is a hospitalist that completed the face-to-face encounter and it is their primary care physician that is signing the plan of care, that Palmetto is expecting to see that the primary care physician who signed the plan of care also signed and dated the face-to-face encounter progress note. Is that not true?
So we get into the simple 3-box diagram, and here we go. The expert saved. Thank you.
Thanks. No, this is an excellent question. Let's put it in context. The words co-signature, in the context of what was going on at Shands, the primary care physician was thinking, I'm approving this individual's language. So we said, let's take that concept of co-signature, just like an attending would approve a resident's language, right? Let's take that concept out. What you're really doing is acknowledging that the face-to-face took place that day and incorporating this into your record. So it's a matter, some people may say, well, it's semantics, right? But not for the primary care physician. So that's the way so it's really a clarification of language, right?
But Palmetto is still expecting to see that signature. It's just the way we're presenting
Yes.
to the physician.
Correct.
Thank you so much.